April Journal of Vascular Surgery online journal club. We have a lot of great guests here, and we're very excited about the content this evening. We're doing 2 editor's choice papers. The first is from the current version of the JVS, which is Dr. Scully, and he is here. We're very grateful to have him be able to discuss his work. And the second is from the JVS Venous Journal. And Dr. Jahara is also here with us today. And so we're going to kind of go through both of these, which is exciting. Our 2 sponsor institutions tonight are Mount Sinai. Dr. Daniel Hahn is the faculty that will be discussing the paper from Mount Sinai. And we have a 4th-year resident, Dr. Vivek Prakash, from the University of Buffalo, the Jacobs School of Medicine and Biomedical Sciences. We're very pleased to have Dr. Rivero and her resident, Dr. Reilly, that will be presenting as well. With that, we have our 2 author guests, which I mentioned before for both papers, which is, it's always nice to have the authors. They really provide a perspective about the work that's really unique, and it's a great opportunity. But we have special guests as well to discuss the work because they're content experts in these areas. And that includes Dr. John Kersey and Dr. Cynthia Shortell, as well as Dr. Adam Beck and Dr. Peter Lawrence. So without further ado, we'll get started. Please keep yourself muted. Put questions in the chat. We will have the discussion of each paper, so please feel free to put your questions in the chat. Do remember that the event is being recorded for demand access. And then of course, we will have our May version on May 13th. The University of Southern California and the University of Washington, it's a West Coast event that time we'll be hosting. And we will go ahead and get started. I'll stop sharing my screen so we can do that.
Well, good evening, everybody. Thank you so much for that introduction, Misty. And thank you, Misty, and for putting this together. What an incredible series this has been between you and Paul. Putting this together has been absolutely successful, and what an incredible group of guests that we have tonight. And I'm looking at the participant list, and most importantly, I see a lot of trainees, including 2 of my incoming interns. So perfect. I think this is going to be perfect. Let me share my screen to get this started. All right. Can everybody see this nice GIF video here? The open AAA repair, it's been described by a lot of my mentors as the Cadillac operation of vascular surgery. You open the abdomen to expose the largest artery in the human body, which through arterial wall and extracellular matrix degeneration has become pathologically bigger. You're faced with the pulsating abdominal mass, sometimes, like in this case, with intramural thrombus peeking through the wall, threatening to rupture at any time. I see my boss, Dr. Peter Ferris, on the call as well. I don't know if you remember, this is your case where like the mural thrombus was literally on the verge of rupturing out of the aorta. Surgeons throughout history attempted to treat the abdominal aortic aneurysm in several ways, including ligation, endoaneurysmorrhaphy, wrapping with cellophane, before we got to the modern open AAA repair, which consists of clamping the aorta above and below the level of the aneurysm, open the aneurysm sac, sewing a prosthetic graft to the healthy aorta, after which the aneurysm sac is rewrapped over the graft and the abdomen is closed. An elegant procedure, but a big procedure nonetheless. With a 30-day mortality for elective repair in contemporary series ranging anywhere between 1% to 5%, and a long list of potential complications, including myocardial infarction, renal failure, pulmonary insufficiency, pneumonia, bowel ischemia, wound infection, etc. Then in 1990, Dr. Juan Perotti in Buenos Aires performed the first endovascular aneurysm repair, where the AAA was relined from the inside using an endoprosthesis that was delivered to the femoral arteries. And then in 1992, my mentor, Dr. Michael Marin, along with Dr. Veith and Sean Holtz and Dr. Perotti, performed the first EVAR in the United States at Montefiore Medical School, Montefiore Medical Center in New York. The endovascular aneurysm repair as it exists today offers the advantages of being able to fix the aneurysm in a minimally invasive fashion with lower perioperative morbidity and mortality, shorter hospital stay. You can avoid general anesthesia and perform the procedure on the local and regional, and now can even be performed percutaneously through 2 small incisions in the groin without any major surgical incision. While there have been a couple studies over the last couple of years that have brought up concerns about the long-term durability of EVAR, several other modern series demonstrate that EVAR can be performed with low long-term aneurysm-related mortality, delayed rupture rates, and can even be applied in patients presenting with the ruptured AAA, which result in lower length of stay, lower mortality, adverse events, and higher one-year survival. Unsurprisingly, as EVAR technology became more and more adopted by vascular surgeons across the country, the rates of EVAR skyrocketed 67% between 2003 to 2013, while open AAA repairs decreased by 76% in the same time period. However, you see a lot of vascular surgeons on the call tonight. I think everyone will agree that the open AAA repair will never go away. There will always be patients who will need an open AAA repair. Patients with unsuitable anatomy for endovascular repair, or those who have just failed, continuous endo leaks with aneurysm growth, failure to seal, graft infection, or in some patients who are young and healthy, the benefits from an open repair may outweigh the risks. But if we are doing fewer open AAA repairs, do our outcomes change? We have both Dr. Scaley and Dr. Beck on the call tonight, who have published this in 2018. Hospital volume is associated with abdominal aortic aneurysm repair mortality. Specifically, while there is no volume effect for in-hospital or 30-day mortality after EVAR, there is a significant volume outcome relationship after open AAA repair. To reword that, complications rates are significantly lower in hospitals that do more open AAA repair. And this brings us to the paper that we're going to discuss tonight. If hospital volume is associated with patient outcomes, what about individual surgeon volume? Is the number of open AAA cases surgeons perform annually associated with patient morbidity and mortality? And Dr. Scaley and Beck have continued their work to bring us the paper that we're going to talk tonight. And with that, I'll turn it over to our wonderful PGY4 vascular surgery resident, Dr. Vivek Prakash, who will review the paper for tonight. I have high expectations, Vivek. Let's do a good job.
Thank you, Dr. Han. I'll go ahead and share my screen here. All right. Good evening, everyone. Thank you, Dr. Humphreys, Dr. DiMuzio, and the JVS for the opportunity to participate in this journal club today. My name is Vivek Prakash. I'm one of the fourth-year integrated vascular residents at the Mount Sinai Hospital in New York. And I'll be presenting this paper entitled "The Association Between Surgeon Case Volume and Years of Practice Experience with Open Abdominal Aortic Aneurysm Repair Outcomes." The association between volume and surgical outcomes for procedures in general and specifically for open aortic surgery has long been a subject of interest and inquiry in the academic surgical community. Just to review some of the more recent literature, in 2017, Zetterval and colleagues published a study in the JVS looking at over 120,000 Medicare patients, which included both EVAR and open aortic repair patients. Whereas for EVAR cases, it was hospital volume, but not individual surgeon volume that made an impact on mortality. For open aortic repair, both higher surgeon volume and higher hospital volume were associated with lower perioperative mortality. Mao and colleagues published a paper in JAMA Surgery in 2017, looking at very low volume surgeons defined as having an average of less than one open aortic case per year. And they found that this cohort of surgeons had a twofold increase in hospital mortality rate, as well as an increase in number of other outcome metrics. The conclusion that operative mortality and outcomes may be related to case volumes has prompted much discussion on what minimum case volume thresholds should be, and conflicting thresholds have been published by various leading groups. The Leapfrog group standards put out in 2004 recommended a minimum hospital volume for AAA repair at 50 cases annually. The SVS practice guidelines published in 2018 recommended that hospitals performing elective open aortic surgery should be performing at least 10 cases per year with a mortality rate of less than 5%. The European Society for Vascular Surgery Clinical Practice Guidelines in 2019 recommended that hospitals should have an average annual volume of greater than 20 cases per year. However, as Dr. Han also pointed out in his introduction, most of the work in these recent years is focused on hospital and institutional volumes rather than individual surgeon experience and volumes. And as such, the purpose of this paper we're discussing today was to examine surgeon annual case volume and years of practice to determine their association with the outcomes of open aortic repair. All procedures in the VQI Open Abdominal Aneurysm Registry over a 16-year period from 2003 to 2019 were included, which included a total of over 12,000 procedures. Only infrarenal or juxtarenal repairs with infrarenal anastomoses were included. Cases involving a renal reimplantation were included, whereas those with a mesenteric reimplantation were excluded. Ultimately, 11,900 procedures were included for analysis. Surgeon experience categories were created as follows: less than 5 years of experience, 6 to 10, 11 to 15, and 16 or more years of experience. And we see in parentheses the number of surgeons that fell under each of those categories. The primary endpoint in this study was 30-day mortality, and the secondary endpoints were major complications and 1-year mortality. Low volume surgeons were defined as those with 5 or less cases annually, while high volume surgeons were defined as those with greater than 5 cases annually. Based on the 4 experience categories previously defined and the high versus low volume categories, an 8-level variable was created for further analysis, which essentially included each combination of volume and experience, as is shown in this table. Chi-squared test and analysis of variance were used to assess univariate associations between the experience factor or the 8-level variables and patient and procedure characteristics or outcomes. Logistic regression and Spearman correlation were used to assess possible trends across increasing levels of a surgeon experience, and a multivariable mixed effects logistic regression was performed for each outcome measure. A total of 11,900 patients were ultimately included in the analysis. Of these, 70% of these cases were elective, whereas 30% were non-elective. And a total of 1,531 surgeons were represented across these 11,900 cases, with a median surgeon annual case volume of 5. And surgeons with greater experience were noted to be more likely to be high volume surgeons, that is greater than 5 cases per year. Shown here are the unadjusted outcomes data for the primary and secondary endpoints stratified by surgeon experience and volume. For ease of presentation, the authors chose to combine the latter 3 experience categories, that is anything greater than 5 years of experience, into one. However, the data analyses were performed for each of those 8 experience and volume combinations previously shown. Practice experience was found to have no association with unadjusted mortality, but there were less complications amongst more experienced surgeons. High volume surgeons had better 30-day and 1-year mortality rates than low volume surgeons, irrespective of experience level. And in this table here, you can see that for, to take 30-day mortality as an example, for early career surgeons with greater than 5 cases per year, mortality rate here is around, it's 20 and 18 for late career surgeons with greater than 5 cases per year, compared to 32 and 31 respectively for surgeons with less than 5 cases per year, irrespective of whether they are early or late career. This forest plot summarizes the risk-adjusted outcomes data for elective and non-elective open aortic surgery. We see that high volume surgeons with 6 to 10 years of experience had the best 30-day mortality outcomes. When looking at in-hospital complications, again, high volume surgeons with 6 to 10 years of experience had the best outcomes. While experience alone was not individually associated with increased 30-day mortality, both experience and volume as separate factors were associated with increased in-hospital complications. Surgeon experience was not associated with decreased 1-year mortality, while increased surgeon case volume was associated with decreased 1-year mortality. No significant interaction was found between volume and experience in both the analyses for mortality as well as for complications. Shown here are the model predicted mortality curves for each experience category across increasing individual surgeon volume levels. And we see clearly here on the latter half of the chart an inflection point at 5 cases per year, above which we see improved outcomes. In this case, decreased mortality. In the figure on the right, which is for all open aortic repair, including elective and non-elective cases, the inflection point, which is around 5 cases per year, and the general shape of the curve is roughly the same, regardless of the experience level of the surgeon, which points towards a lack of interaction between volume and experience. This paper represents one of the only analyses of registry data to examine the interaction between volume and experience as it pertains to open aortic surgery outcomes. A number of important key points can be concluded from this work. Firstly, surgeon case volume appears to be more important than years of experience in predicting mortality and complication outcomes. Independent of practice experience, an open aortic case volume of greater than 5 cases per year is predictive of better outcomes. Both early and late career surgeons are vulnerable to the effects of decreased case volume with regards to open aortic repair outcomes. And notably, there was a lack of interaction between volume and experience across all analyses. And this may be in part due to the recent adoption of EVAR technology, which, as we have said, can affect both early and late career surgeons. There are a few limitations to this paper that are worth discussing. Given the use of VQI registry data, which includes a wide range of patient variables, it is possible that the risk adjustment performed was incomplete, and this is something that the authors acknowledged in the paper. Also, given the use of VQI registry data, the results may not necessarily be generalizable to hospitals and surgeons that are not participating in the VQI registry. The exposure to open aortic surgery during training is not accounted for in the current analysis, but it is thought that this can have a potentially large impact on the outcomes of early career surgeons, especially those in that 0 to 5 years of experience category. Additionally, non-aneurysm open aortic case volume is not accounted for. For example, aortobifemoral bypasses performed for occlusive disease would not count towards the aortic case experience of a given surgeon as far as this analysis was concerned. This paper leaves us with a couple of important considerations for the field of vascular surgery going forward. These include what are appropriate institutional and surgeon-specific case volume minimums for credentialing for open aortic surgery, and how can low-volume surgeons be paired with high-volume surgeons to achieve optimal outcomes. And that's all. Thank you so much once again for your attention.
Well, thank you, Dr. Prakash and Dr. Hahn, for that wonderful introduction. I thought it is really interesting, and just looking at the paper in general, luckily we have Salas here to talk to us a little bit, because I'm sure that we're going to have a few more questions, and I'll start it off while people are putting their questions in the chat. But the volume issue, do you think this is a systems thing where we're seeing hospitals that have these systems in place that are really able to rise with better anesthesia, better catchment, or better rescue kind of things? What do you think the results are really reflecting here?
It's a great question. First, I wanted to say thank you for highlighting our article. Also, on behalf of Dave Stone, the senior author, he was unable to make it because of a conflict, but he also appreciates it. I'm grateful that Adam's on the call because he was instrumental in the publication. But to your question, Misty, I think all of those are relevant and important. I think the volume unto itself, the variable and the presupposition that volume equals quality, because that's what we're putting credentialing paradigms on. That's what's behind societal statements. I'm not sure that that's a complete way to assess quality and outcome. That was what we were being provocative in saying. It was the old adage, if you've done a bunch of open aneurysm repairs over the time in your career, and then as your career sort of is in its twilight, and now you're only doing a few open repairs, is it like riding a bike and that you're going to have as equivalent outcomes as you did earlier when you were higher volume, and vice versa? If you're a young surgeon doing a lot of high volume repairs, can you get similar outcomes as that older surgeon who's doing high volume repairs and so forth? And we found that volume is really the great equalizer, but experience matters. Certainly in the clinical decision-making and patient selection, we see clear differences in the conduct of the operation, cross-clamp position, blood loss, expediency of the operation. So it's a difficult question to sort of characterize and say, is it institution, anesthesia, rescue, the failure to rescue, or is it the surgeon? I'm sure all of the variables interact, and that's where the complexity lies. That's why we did our best in the risk adjustment to make a fair comparison and of looking at volume, experience, the combination of volume experience. We looked at both as categorical and continuous variables. I think we created over 35 different predictive models to try to pull out sort of what, to read the sort of the litmus leaves on this, to sort of understand what is relevant, what is important to all of this, because I do think it has major implications. It's gotten a lot of notoriety. We recently had an op-ed that we put in JAMA Surgery, sort of speaking to this larger issue about credentialing at hospital and surgeon levels, because these leapfrog and the Society of Vascular Surgery, European Society of Vascular, CMS, they all have different thresholds. So what is the right threshold? Is it institution, surgeon, both? And why is the number different? And frankly, we're doing less open aortic surgery now than we ever did before, yet the volume thresholds have decreased. So again, to your question, is it because we've gotten better at the operation, or the institution's better? Are we better at selection, or is it all of the above? And what if you don't happen to do the specific threshold, but you still achieve really good outcomes? Should you not be allowed to do that repair? And so I think that we were trying to be a little bit provocative to make these sort of thresholds maybe a little bit more pliable, and sort of make a plea that there are other really relevant variables that need to be considered in the overall equation and risk adjustment.
And I'll go through the questions that are listed here. Were you able to adjust anyway for kind of patient factors? You know, Dr. DiMuzio asked, do you feel like it's more experience that leads to better judgment? So you're knowing who to operate on or who not to operate on. And you kind of touched on that a little bit.
Yeah, our a priori risk adjustment model included 21 different preoperative patient and intraoperative factors. Those were pre-selected based on the known literature surrounding AAA outcomes and predictions, based on, you know, cross clamp, aortic exposure, intraoperative adjunctive procedures, but also all the comorbidities that sort of are predictive. So I do think that patient selection has something to do with it. It looks like I said, the conduct of the operation for the more experienced surgeon, the best thing was the most experienced, highest volume surgeon. It's true that the less experienced high volume surgeons had near equivalent outcomes relative to the older high volume surgeons, but the older high volume surgeons had the best overall outcomes. That's no question. And if you looked at just how the operations are selected, the comorbidity, frequency, intensity, and the conduct of the operations, there are clear differences, meaning the higher volume surgeons and the older surgeons tend to have more intra or infra-renal cross clamps, whereas the younger surgeon who's not as busy doing open repair tended, when they were doing open repairs, more complex repairs, more adjuncts, longer operative times, more blood loss. Now, this may be, like you said, referral bias. That younger surgeon who's being inculcated into the practice just isn't seeing those aneurysms, or it's the bias towards their comfort level of what they can do, which is endo. And when they can't do endo, they're faced with doing the more challenging aneurysm repair. But we can't adjust for the partner response. You know, that's another thing that's an incomplete adjustment, is we don't know who's on the other side of the table. I know at my own institution, when Adam was there, when we were partners, we could do an aneurysm together. Whereas now, you know, I can't control for something like that in the VQI, where if there's a junior surgeon who's operating with, like you, Misty, I don't know that you're there and helping that operation. So it sort of raises a lot of questions about the volume, the practice experience, and the inculcation and referral patterns and patient selection. So it kind of all goes together.
What do you think this means for training? I mean, we talk a lot about residents coming out, their number of open cases. How do you think that this number really affects what our trainees will be able to do when they get out?
I think it's a great question. I don't know that I have the exact or the best answer for that. All I can say is that it's going to be critical for any trainee, irrespective of what program, whether or not they had a huge experience with open surgery or not, whatever program, because you're not protected over time. If you like, that's one thing the analysis does show, is that as you get older in practice, and if you're not doing as much open surgery, your outcomes suffer. Like I said, the volume was a great leveler. So it's going to be really important with the onboarding process that you identify, you know, programs and or practices where you truly feel like you're going to be mentored. Hopefully there is some type of referral that's set up to sort of protect that surgeon and to sort of help them. At the very least, your senior partners need to be across that table, or at least there needs to be an open opportunity where you get direct mentoring, and that continues probably throughout your career. Because like I said, the older low volume surgeons were also vulnerable to poor outcome.
There are a lot of questions. Dr. Rushing is asking about how this really applies to the suprarenal and the thoracoabdominal interventions. Do you have some thoughts on that?
I would assume it would be magnified, but I don't know for sure because we don't have that data. The short answer is I assume it would be magnified because it seems like everything's magnified for that. When the complexity goes up, you have more endpoints, right? And so I suspect that it'll be even greater. That being said, we'll have an even smaller cohort of surgeons and centers that would actually contribute those more complex repairs. So maybe that gets equalized just by virtue of the fact that we are already, for some of these types of operations, instinctively and naturally getting patients referred to these higher volume institutions just by virtue of the sheer complexity.
I definitely want to get to a couple more of the questions, but Dr. Beck, I'd like to invite you to say a few words about this and what your thoughts are.
Thank you. Actually, if I could just address a couple of things, maybe to just hammer it home what Sal just said about, and what Amanda's question was about what we don't have. These are all infrarenal repairs, or at least infrarenal anastomoses, which is probably important to point out as a deficiency in the VQI data. And you might assume that people, centers, surgeons that have a lot of infrarenal anastomoses also do, more suprarenal thoracoabdominal cases, and so this might then apply to that as well, but we don't know that, and so it is a bit of a deficiency in the VQI data. We're hoping to capture more of those complex open procedures in the future. Dr. Shortell's question, I think, is a really good one. Why is that 6 to 10 years practice a sweet spot? I don't know the answer to that. It is pretty clear that the volume is more important than the years of experience, and I we can't emphasize that enough. The point that Dr. Shortell made about why not just follow outcomes, I think that's a good point. There are low volume surgeons who have excellent outcomes. There's no question about it. Probably the point to take home from all of this is that if you are a low volume surgeon, it's probably especially important for you to participate in a quality registry and ensure that you benchmark your data and that you are having the same outcomes as people that are higher volume. And I hopefully that that kind of resonates through all the people that don't participate in VQI, because I think that's one of the values of it.
I think Dr. Glebitsky brings up an interesting point here. In cardiothoracic, a lot of people do these super fellowships. Even when they were not doing the I-6 program, when they were doing a couple of years of CT, they would go into transplant super fellowships or all of these other things. Should we start an aortic fellowship? Do you need to have an open aortic fellowship or places where you go to these large centers to do one as a super fellowship after you graduate residency?
Is that for me, Misty?
Either one, both of you jump in. I think it's,
Yeah, I think it's a good idea. I guess the question then would be, how much volume do you have to do to be kind of a center of excellence that can have a fellowship, and would that be something that we would be prescriptive about at a society level? It probably makes sense to do that. I know that there's a huge disparity in the amount of open aortic surgery that people do across the country in their various fellowships and residencies. And that's one of the most common questions that we all get, I think, when we're interviewing residents and fellows now. And so I think we should be open about those numbers, and we should probably give some consideration to that as we see more and more of these data that suggest that you really should be doing more cases to get better outcomes, because the patients are the ones that they have no idea. They have no idea how many open aortic surgeries you do in a year. If you sit in clinic and tell them that they need an open aortic surgery, they trust you. They trust that you do enough to keep them safe. And I think that it's probably important for us to put the patients at the center of all those discussions.
I think that's really something beautiful there. Dr. Lawrence and also Linda Harris asked the same question, basically about simulation. Sal or Adam, do you think that simulation can overcome some of this low volume? Do you think there's a way to do simulation in this regard?
Adam, I could take that if I could at first. I think simulation is going to be important, certainly during the training. I don't know how you can sort of integrate that into the everyday practice of a busy surgeon once they've been established in practice, unless it was somehow mandated for them. That being said, I think the technical conduct, while very, very important for the operations, I can identify that most of the risk factors that we controlled for were related to the preoperative features. So I think a lot of that patient selection, and then also being in institutions with good critical care and failure to rescue. I think it's sort of back to the original point of why do high volume hospitals do better? We've never really understood the mechanism, right? Same thing, we don't understand the high volume surgeons. Everybody thinks it's just rehearsal and technical features. And I think there is something to that, but it doesn't answer the full question. While I think that there is value to be gained there, I'm not sure how you would use that over time during the career of an established surgeon. Certainly it's easier to implement it during the training unless you had some type of incentives set up where these low volume surgeons who may or may not be at some designated center of excellence are required to create or complete some sort of minimum training proficiency by a proctor every couple of years. You'd imagine all of the challenges that would come to sort of getting that done, and who's going to oversee that, and how's that going to be enforced. But I do think there is value to be gained, certainly at the training level.
We'll finish off the questions for this particular article about what do they do in Europe. I actually don't know this. I don't know if Sal or Adam, you know, do they have centers of excellence in Europe? How do they do this?
To my knowledge, they do not have centers of excellence. It's similar to the U.S. and we do have that paper that Sal wrote about the international consortium paper. The data look very similar to the United States, and that volume matters, and for open repair, that is. For EVAR, interestingly, it doesn't seem to matter, or maybe the effect is just a little more nuanced, but to my knowledge, they do not have specific centers of excellence now.
What they have, Misty, is that simulation is part of the board exam. And Peter Lawrence may know more about this, but they have been doing simulation much longer than we are, and open aortic aneurysm repair is part of the board exam.
In fact, before any resident starts their training in most European countries, they go to what's used to be called the Pontresina course, which is in Pontresina in Switzerland, and they are trained the Pontresina technique for corner stitches, and everybody does simulation one way, and they're all trained to do it identically, and then they go and do their residency program. I've been over there a couple of times and watched it. It's very impressive, but whether or not it translates into years later is hard to know, but certainly every resident gets training in a boot camp for 3 to 4 days before they start their residency.
I mean, I personally think that simulation is most impactful at the early years of training, which sounds like that's what they're doing, both endovascular and open. And for the young folks on here, my personal bias is that when you go to look for a job when you're done, you want to have people in the practice that are experienced with these things so that they can help you, because you're not going to be coming right out of training ready to do, a complex thoracoabdominal aneurysm, but that doesn't mean that you can't do it. You just need to, get further mentorship from your partners. So you want to look for partners that are willing to do that with you.
I think that was the biggest thing when I was starting off as well. It's being part of a hospital system where you have senior partners who are willing to share the cases with you so that you get experience is a big thing. I mean, when you're a first year attending coming out, you're not getting the lion's share of aneurysm repair referrals. Those are difficult to come by. And when they do come by, you have to have senior partners who are willing to kind of teach, and so that your case volume stays up. I think, I completely agree. That's probably is one of the most important things for junior attending starting off.
Yeah, and I think, one of the things, Dr. Kersey, we're talking about volume. You're a expert in, aortas and in basic science in that region. Volume is decreasing. Is this going to be a little bit more rare? Are there areas where we might think about doing things a little bit differently?
That's great, Misty. Thanks for letting me join here. And I think it was a great presentation, by the way. It was just really, really well done and described this paper really well. There's the old saw, good judgment comes from experience, right? And how do you get experience? Well, bad judgment, right? So there's really no replacement short of doing the cases. And one of the things I take away from looking at the numbers, and this doesn't directly address your question, I'll get to it in a second, Misty, but is that even the worst outcomes of these groups really don't look all that bad in the elective setting. You kind of look at the ruptures, and now you've got some differences that show up a little more apparently, and those are harder to deal with for sure. But I think we can be reasonably confident that we're doing a pretty good job of training our trainees. They're coming out doing a pretty darn good job. The power of this study is huge, and so very small differences are easy to see. And so you can see those differences, and they're real. but I don't think we should be wringing our hands too much, but using this to continue to develop our educational processes to help each of us get to that point where you've had the bad judgment that leads to the experience that leads to the good judgment. As far as, you know, the complexity of the open repairs, certainly over the past 10 years is certainly different than they were, you know, 20 years ago, 25 years ago. The long neck, simple clamp things where you can get some of those early easy cases are gone. And so, because they're all being done endo. So it's always under a more complex situation, and that amplifies these differences as well, I think, these days. But the biology of it is still not well understood, and how to use that to improve our outcomes, I think, is still a ways away. We still have a lot of work to do to use the biology to really improve what we're doing. I would say that I always get a little black fingernails on the blackboard sort of feeling when somebody says this is an aneurysm repair, because Lord knows I'd love to repair an aneurysm. What we do is replace it or exclude it, but we don't actually repair any of them. And I'm hoping for the day come that we can actually repair these things. But that's going to still be a bit away. But thanks again.
Of course, that's a unique perspective. We all have our pet peeves of things people say. You know, there's, you know, palpable or Dopplerable pulses, or, you know, whatever that. I have not thought about that, repair versus replace. So that's really interesting. Well, I appreciate everybody's insight and all the commentary. It's really great to have that aspect of this, but we are going to move on to the next paper. And Dr. Rivero, I'm going to have you start your introduction.
Yeah, hi guys. It's really great discussion so far, and it's a real pleasure to be a part of it. Thanks so much for putting this together and including us. So I'm just going to share my screen here. All right, so iliofemoral venous stenting has been one of the real success stories of the endovascular era, particularly in the situation of non-thrombotic disease. This is obviously interesting for a variety of reasons, but one of them is that there's a lot of unique challenges to stenting in veins, and until quite recently, there have not been purpose-built stents for the venous space. So when stenting veins, you typically need quite large diameter stents, and they need to be flexible in order to accommodate the tortuosity of the iliac veins. And while being flexible, the stents also need to be quite strong because they have to be able to withstand the extrinsic compression that occurs at various anatomic choke points, and also potentially in cases of malignancy. So thus far, the vast majority of venous stenting has been done using the Wall Stent, and that's primarily because it's been one of the only stents available with large enough diameters. But also the design with the sort of braided design of the stent makes it quite flexible. There are some issues, however, using the Wall Stent. First of all, it has relatively weak ends relative to the center of the stent, such that if you were to position it exactly at the iliocaval junction, you're necessarily placing the weakest part of the stent in an area where you potentially need significant radial force and compression resistance. But also Wall Stents tend to foreshorten as you deploy them, and even more so when you post-dilate. And so it can sometimes be difficult to land them exactly where you'd like them. So for many years, the prevailing wisdom was that in order to minimize the chance of missing a critical lesion at the iliocaval junction, Wall Stents should be extended at least several centimeters up into the cava. I think looking at the picture here, the potential issue there is sort of obvious. You're now extending your stent across the venous outflow of the contralateral limb. The Wall Stent has relatively tight interstices, and these can develop a pseudointima, so this is a potential source of obstruction. And indeed, groups that were using a lot of Wall Stents began to notice patients presenting with contralateral DVT. So in response to this, the group whose work we're going to be looking at today, they started seeing some patients show up, and so they changed their stenting technique. So now they have switched over to a modified technique, combining a Wall Stent and a Z-stent. So in this technique, the wall stent is placed really just up to the cava. And then there's a short iliocaval extension with a Z-stent. This has the effect of increasing the strength right where you need it in that common iliac segment. But also there's, first of all, just a little bit extending into the cava. And the part that does extend into the cava consists of a stent with these wide open interstices. So there should be less resistance to outflow. So when this group looked back at their data after having adopted this modified technique, what they found was that in the Z-stent group, there was almost no cases of contralateral DVT, but there were a significant number of contralateral DVTs in their sort of historical wall stent comparison group. So in some respects, this is sort of definitely data in favor of the Z-stent, although I think it would be more accurate to say it's data against the cable extension technique. But that obviously doesn't really answer all our questions. Vein patients, as we know, tend to be younger than our arterial patients. We're typically treating them for non-limb threatening conditions. And so long-term outcomes and durability are particularly important in this population. And so that's really what the paper we're going to be talking about tonight is seeking to address. What are the long-term outcomes of this technique? This is also an important moment to be having this discussion because for the first time, we have several FDA-approved venous stents. Although, as I learned yesterday, the Vici stent is now going to be subject to a voluntary recall. But regardless, we now have several venous stents available to us. And so looking at the Z-stent data is going to provide an important benchmark against which we can compare the performance of these new stents. So with that, I'm going to turn things over to Dr. Brendan Reilly, who's our 5th-year resident, and he'll be our discussant for the paper tonight.
Yeah, I think this recall is going to have some questions going on as we move through it, through this talk.
All right, thank you. Thanks, Dr. Rivero, for the background and for the introduction again. I'm Brendan Reilly. I'm a vascular surgery resident at the University at Buffalo. And thanks again for the opportunity to be involved in the Journal Club. I'm gonna speak about a paper by Dr. Jaharaj and Dr. Raju out of the RAIN Center entitled Long-Term Outcomes Following Use of a Composite Wall Stent, Z-Stent Approach to Iliofemoral Venous Stenting. So most of the background Dr. Rivero already went over, but essentially endovascular therapy, namely venous stenting, is now the primary means of treating chronic iliofemoral venous disease. The wall stent is very widely used. It's been around for a while. It's well studied and has positive outcomes. But as Dr. Rivero outlined, it has its own problems and pitfalls. The authors of this paper brought about the idea of composite stenting as a potential solution to some of these problems. And they have considerable experience with it now. So one of the goals of this study was to evaluate their clinical and stent-related outcomes and compare them to historical wall stent data. This is a single center retrospective analysis of prospectively maintained data from 2014 to 2017 at their tertiary center that specializes in the management of venous and lymphatic disease. Inclusion criteria included essentially typical symptoms of chronic iliofemoral venous obstruction in patients that also had evidence of obstruction on IVUS. Patients who presented with acute thrombotic disease, who underwent thrombectomy, lysis, and subsequently were stented were excluded. And again, comparisons were made to historical wall stent data. The composite stent configuration was previously outlined, but it includes a wall stent body with a Z-stent top. Patients in this study were preoperatively placed on a prophylactic dose of Lovenox and were then prescribed 6 months of therapeutic anticoagulation thereafter, in addition to a combination of aspirin and Pletol. They were prescribed compression stockings and instructed to use them every day. They were surveilled with duplex on post-op day 1 at 2 to 4 weeks, 3 months, 6 months, and a year. Clinical measurements were made preoperatively and postoperatively with visual analog pain scores, grade of swelling, VCSS, chronic venous disease quality of life questionnaire, and they kept track of reintervention rates and patency data using duplex. The study captured 545 limbs and 535 patients. About 2/3 of the patients were female with a median age of 60 years. The overwhelming majority of patients were treated for post-thrombotic stenoses with 441 limbs, and the remainder were non-thrombotic iliac vein lesions, so more compressive type lesions in 104 limbs. The distribution of SEEP scores is outlined here, and you can see that the majority of patients being treated were being treated for C3 and C4 disease. The median follow-up was 26 months. Some of the main clinical outcomes seen with composite stenting were that pain and swelling improved. They saw significant improvement, and this persisted through 24 months of follow-up. 60% of patients had complete relief of pain, 25% had partial relief of pain, 15% saw no improvement, and 3 worsened. There was significant improvement in the VCSS scores and quality of life measures, and these persisted through 24 months of follow-up. Of the patients that initially had complete resolution of their pain, 73% ended up having some element of recurrence of pain and swelling. Of these patients, 22 ended up requiring reintervention due to recurrent disabling symptoms. The ulcer healing rate was 73%, and of those that healed ulcers, there was a 34% ulcer recurrence rate, with the median time to recurrence being 23 months. The overall primary patency for composite stenting was 70%. Primary assisted patency was 99%, and secondary patency 91%. These are all pretty similar to previously published data with the Wall Stent. The reintervention rate was 20%, and this included indications like in-stent restenosis, stent compression with in-stent restenosis, and stent occlusion. The rate of contralateral iliofemoral thrombosis was 0.2%, and this was 1 limb. The need for contralateral stenting occurred in 5.5% of cases. So just to summarize, sort of the key clinical findings here are that composite stenting does pretty well and compares similarly to the Wall stents. The pain, swelling, VCSS, quality of life measures, ulcer healing, and recurrence rates are all similar to Wall stent, as are the patency and rates of reintervention. The main difference lies in the rate of contralateral iliofemoral venous thrombosis, which only occurred in 1 limb at 0.2%. And this compares to 1 to 10% previously described with the Wall stent alone. In addition, the need for subsequent contralateral stenting occurred in only 5.5% of cases, compared with 13% for Wall stent. There are some limitations, including the retrospective nature of the study and it being a single center with historical data to compare to, and there was some loss of follow-up. Despite the limitations, I think there are several important conclusions that can be drawn. One, I think this reinforces that endovascular venous stenting does represent the standard of care for these patients. And composite stenting mirrors the positive clinical outcomes that we see with Wall stent, but offers significantly less need for contralateral stenting and can offer patients a lower risk of subsequent contralateral DVT. So I'd just like to thank my mentors and everyone involved in putting the JVS Online Journal Club together. And thanks for including us in this month's edition. And just before I hand it over to the discussants, I had a couple thoughts and questions of my own from reviewing this paper and some of the previous papers. So the first one is for the authors, and this group published this technique in 2014 initially, I think, with a series of 217 limbs, and this technique has been used since 2011, and the results are pretty similar and they're all positive. I just wonder, is there some difference in technique or other reason not to include these patients as to allow for a more robust patient population, potentially with longer term follow-up? My second question is, how have the venous approved stents changed your practice patterns, and where does composite stenting fit into your paradigm now? And lastly, I was just interested to hear your thoughts on deciding on this anticoagulation antiplatelet regimen, and maybe how some other people manage anticoagulation and antiplatelets in these patients. Thanks again for your time.
Well, thank you, Dr. Reilly. I appreciate that. And I'd like to start by asking Dr. Jaharaj to maybe address a couple of the comments that were just brought up by Dr. Reilly.
Yeah, good evening, everyone. On behalf of all the authors, I would like to thank Dr. Humphreys, Dr. DiMuzio, and the journal for highlighting our paper. Thank you. So with regards to Dr. Reilly's questions, why did we not include the the 2011 to 14. Any new technique takes some time to mature and perfect. And so there's a learning curve for that too. And the 2014 through 17 period is where we felt that our technique was essentially as close to perfect as it could be. And so that's the reason for that. Where does composite stent fit with regards to interventions in the setting of available dedicated venous stents? That's an important question. And I think the data on the dedicated venous stents are going to be coming out as time goes by. I don't think we have enough data to make definitive arguments one way or the other. Our personal practice, I found that in recanalization cases, the composite stent configuration probably offers advantage over the dedicated venous stents, at least as far as practice goes. Our experience has primarily been with the barred Venous stent. And so with regards to stenotic lesions, I think given the fact that you have longer stents that have essentially similar properties to the Wall Stent Z-stent combination, we've moved to using the dedicated venous stents. Now, with regards to the third question pertaining to anticoagulation, the current practice is for us to use anticoagulation only in those patients who were already on anticoagulation to begin with, or who have thrombophilia that was diagnosed at the time of workup of these patients, or in recanalization patients. Apart from that, our practice has been to essentially use low-dose aspirin, 81 milligrams. And if the stent were to develop complications down the road, as in like occlusion, then we might add anticoagulation. So anticoagulation has sort of gone away from our standard sort of post-operative medication regimen.
Well, thank you. And we're lucky to have a couple of really great experts in venous disease. And Dr. Shortell, you have a couple of questions in the chat. I'd love it if you could unmute and chat with us a little bit about those.
Thank you. And just fantastic presentations and discussions, and wonderful to have all the experts and the authors here. I mean, it's just an amazing program that you've put together. And I've already emailed my program director to say that we have to make this a mandatory event for our trainees. So my questions, I think, are similar to the questions that were posed by the presenter, by Dr. Reilly at the end of his excellent discussion. But I'm just wondering, and I think, Arjun, you're saying that you've transitioned to the dedicated venous stents, because I was wondering, since you've perfected the Wall Stent Z-stent combination so well, whether you thought that it would be competitive with the dedicated venous stents in terms of outcomes. So that was my first question. And perhaps your next paper might be to look at your experience with dedicated stents compared to this experience with your hybrid technique. And similarly, I wondered whether you considered, in this particular paper, comparing your robust historical experience without the hybrid technique to the newer technique to demonstrate more formally that it's superior. I know in your discussion you talk about it, but there's no formal statistical comparison.
Thank you, Dr. Shortell, for those questions. Well, the answer to the first one is, the dedicated venous stents have been working well so far with regards to stenotic lesions. And that particular paper is in the works. We are actually comparing our experience with dedicated venous stents. And for that paper, we will have a comparison with the composite stent configuration. As far as your second question goes, no, we didn't do a formal comparison just because of the length of time. There's almost a 20-year experience with the dedicated wall stents with multiple changes in practice patterns over the years. And so it would have been a hard comparison to compare the composite, with the isolated use of wall stents alone. So that was a challenge we faced, and so we decided just to do a historical comparison.
I'm on it. Well, I also, Dr. Harani was asking about the cost. How much is there in terms of the added cost of the second stent?
Well, it varies from hospital to hospital, I would think, and practice patterns. It roughly adds about $1,000 to the cost.
Dr. Lawrence is also joining us as a special discussant, and I saw you put a question in there. Would you like to unmute and chat a little bit with us?
Sure. I actually just saw a patient today with exactly this problem. A year ago, had iliofemoral venous thrombosis after hysterectomy. It was not repaired. It was not stented. It was not lysed. And a year later, she has a CT venogram, which shows a very atretic iliac, external iliac, common iliac vein. And my question is, we talked about what's the likelihood of being able to open this and stent this, and is there ever a remaining role for an open cross-femoral venous bypass? And I'd just be curious as to what the experiences of those of you here. I thought it was a great discussion and a very interesting paper, but occasionally I think you probably are unable to open the vein, but I'd be interested in people who have more experience than we do.
Dr. Jaharajan, are you doing cross-femoral bypasses a lot? What's your experience?
Not for the last few years. No, to answer the question, I mean, you can atretic or even a channel that you cannot visually see. The two P's that work are patience and persistence. And when you do these cases, at least our experience has been sometimes it takes a couple of tries before you're able to succeed. Overall, there's almost an 85% success rate. Now, is a PAMAs or a prosthetic bypass, something that can be done in these patients? Certainly, but as we all know, the long-term outcomes of venous bypasses, be it crossover or femorocaval or iliocaval, are pretty poor. I think the best outcomes are typically seen for iliocaval, but they compare very poorly to recanalizing and actually stenting these lesions.
We are going to try an endovascular approach in this young lady, but I was just curious as to if we're unsuccessful in doing cross-femoral bypass. Sounds like you never have to do that, and that's encouraging.
Yes, especially for a young patient. Yeah, certainly, Dr. Lawrence. I would try the endovascular approach first, and if all fails and her symptoms are debilitating, then I would do a cross-femoral bypass.
One of the other questions is just about the causes of clinical failure. The clinical failure rate seemed a little bit higher than the patency rate, and we were wondering if you could chat a little bit. That was one of the questions in the chat.
Yeah, so I think it all sort of comes down to the basic vascular tenets. How good is your inflow? Is there a problem with your conduit, and how the outflow is? So the same things actually apply to venous stenting as well. And so as long as every case one tries to optimize outcomes with regards to those three variables. But even when you do that, the patients don't always get better. As you see, when you look at pain and swelling, partial and complete relief of pain is around 85%, and partial and complete relief of swelling is only about 70%. And the reason for that is the impact of phlebar lymphedema. And so in those patients who have residual swelling, I think it is important to focus the treatment on lymphedema. And so complex decongestive therapy, which includes manual lymphatic drainage and use of a lymph pump, tremendously helps those patients. As far as pain goes, in folks who, in spite of doing a technically successful stent procedures still have lower extremity pain, I think they might actually have chronic compartment syndrome as a result of long-term venous hypertension. And so in these patients, it's useful to check the compartment pressures. And if elevated, they would benefit from a fasciectomy and fasciotomy. So in people with disabling chronic venous insufficiency symptoms, primarily pain, remember that there are other reasons that could be contributing to your pain, sort of the end result of venous hypertension, and not just the iliac vein obstruction alone.
That's an interesting concept. I don't think I've thought of chronic compartment syndrome in patients with chronic venous insufficiency, or I mean, maybe thought of doing fasciotomy in patients with long-standing chronic venous insufficiency. That's Dr. Lawrence, Dr. Shortell, have you kind of done that in patients? Can you comment on that too?
No, I have not done that, but I was just wanting to reinforce the importance of considering phlebital lymphedema if you have persistent swelling after technically successful iliocaval stenting. I think that's something that's very appreciated and undertreated. And it's also important to, if you can certainly tell when someone has phlebital lymphedema clinically, and I think preparing them for the possibility that they may need comprehensive decongestive therapy in addition to the stenting, it's really important.
We have not considered chronic compartment syndrome, but I just would comment that it's impressive. We've, as you know, have written a couple papers on venous ulcers, and the fact that there's a 70% healing rate with proximal stenting is very impressive. I mean, you add that to ablation of the saphenous vein, closure of perforators. I think in today's world, you can get venous ulcers healed in close to 90-95% of patients if you use all modalities and treat all refluxing and superficial veins and the proximal obstruction.
Dr. Jaharaj, Dr. Hahn had asked a question about, the sizing of these newer venous stents. They're meant to be sized differently than wall stents, less oversizing. But there's also the concern for migration. So can you talk a little bit about how you're sizing your newer venous stents compared to using the wall stent?
Sure. I think that's an important question as more and more stents become available in the US. So I've sort of used Dr. Dabir's paper that was published in Circe a couple of years ago, the physical properties of venous stents, the dedicated venous stents. The only thing that was missing from their comparison was the Abre, the Medtronic stent. So I'm a little reluctant to comment on that particular stent. But I think as far as the Bard Venevo, the Cook-Zilver Vena, and the Veniti Boston Scientific, I know it's under voluntary recall, but I'll still talk about it briefly. As far as the three stents go, and when you compare it to a fixated wall stent, with regards to crush resistance, the fixated wall stent trumps all the other stents. And that's my rationale for still using the composite stent approach in recanalizations. Now, as far as the radial resistive force goes, and as far as the chronic outward force goes, two important properties that are helpful when you're dealing with Bay-Turner syndrome, as well as when you're stenting across the inguinal ligament. The Bard Venevo is actually better than the wall, as well as the Cook-Zilver and the Boston Veniti. So as far as this, taking all that into consideration, I do not oversize the Bard Venevo stent, but I would oversize the Cook-Zilver and the Veniti stent the same way I would do the wall stent.
Dr. Harris has a question in here about doing femoral endovenectomy in addition to stenting for some of these chronic cases. And I have to say, every time I've thought about doing this and I do a venogram, there's like a gazillion branches off the common femoral vein. And I just think, what am I supposed to do with all those branches? So do you do femoral endovenectomy? Have you, is that a part of your practice when you're doing some of these stenting procedures?
We have, but it's extremely rare. More often than not, you can actually extend the stent all the way down to the confluence of the femoral veins, and that usually tends to be adequate. There's always the concern for, is the sort of the scarred common femoral vein, does it have so much of crush force that it's going to crush the stent? We have not really seen that. So, but there is, if the channel across the common femoral vein is, just a pinpoint, 1 millimeter or less, then perhaps it's got some role. But the ACCESS PTS trial and, our own experience has taught us that in an overwhelming majority of patients, angioplasty, sufficient angioplasty prior to stenting and post-dilation of the stent generally results in a good flow channel across that area.
Dr. Lawrence or Dr. Levitsky, do you have a comment maybe on the endophlebectomy? I know that's something, or the femoral phlebectomy. I know that's something that both of you are experienced in.
Well, the endophlebectomy with the stenting was a technique that our group described first, and we did the first cases at Mayo. And we found that it really should be used as a last resort. As Arjun correctly said, most of the time you can go all the way down to the profunda or even stent into the profunda as an inflow. So in the series, the first 12 patients that we reported, we had a 30% patency after 6 months. So it wasn't a very good operation, even though it was not, not all of them occluded. So we saved some stents and created an inflow. But subsequently, Tony Camerota and a couple of European groups did the same thing with an arteriovenous fistula, and they had better results. So I think I would keep that as an option. I think I would certainly try to create an inflow without open surgical dissection, because once you do the dissection, you cannot fully anticoagulate the patient as you can with the stenting, and that is a clear drawback, and those patients can have a hematoma. And since you may, if you use a fistula and you use a prosthetic graft, we had a couple of infections too, so you have to be careful when you apply that.
I would say that, just to add to that, we agree and do not do an endophlebectomy, and we've learned that you can extend the stent down below the inguinal ligament and it doesn't get compressed, and you don't need to do that, and not to sell open surgery. But on those rare cases where you have to do an open cross-femoral bypass, that's the time when we will clean out the common femoral vein before we do the anastomosis. So we don't do it routinely with stenting, but we do it if we ever do an open procedure and a cross-femoral venous bypass.
Well, thank you, everybody, for such a great, robust discussion on two incredibly opposing topics, from the aorta to the veins. And I think that's what makes this a super unique experience. We're very grateful to everybody that has joined us tonight, especially our discussants and our authors of the papers who are really able to bring such great insight. Our next event is in May. Check Twitter. We have it advertised on SVS Connect. There are a lot of we'll put it out there, and we look forward to seeing you at that time.
Thank you, Misty.
Thank you very much.
Thank you.
Nice job. Good
Thanks,
moderator.
everybody.
Thanks, everybody.
Great job.
Thank you.
Take care, everyone. Bye-bye.